And sometimes having that knowledge prior to delivery can change where you're delivering your baby, what specialists are going to be on hand, what kind of medical care they might need, sort of even shortly after birth. And so it's not just about stopping a pregnancy or not stopping a pregnancy. It's also about being prepared and then having all that appropriate medical care as needed at delivery or after birth.
Yeah, absolutely. I think many patients do opt to have prenatal screening to have more information and also really to give them that opportunity to prepare emotionally if there is a chance that their child may have a genetic condition.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Centre, otherwise known as Our Baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
Today, we are joined by Diane Myles Reid, our genetic counselor extraordinaire, and we're going to be talking about prenatal screening, another aspect of genetic care that is also very important in the fields of fertility. And here at Markham Fertility, we're very lucky that we have a full genetic counseling department to help us navigate through all of these things. Diane, thank you so much for joining us.
Thank you for having me. It's my pleasure.
Diane, what is prenatal screening? Like, what does that refer to as opposed to other kinds of genetic testing or genetic screening?
That's a great question. So, prenatal screening is a genetic test. So, this is genetic testing that should be offered to all pregnant people, regardless of their age. This is non-invasive, so it allows people to screen for genetic conditions that can occur in a pregnancy, usually by chance. And it's really meant to determine if there's a higher or lower chance to have a pregnancy or baby with a chromosomal condition, one of the chromosome conditions we can screen for. I think it's important to keep in mind that it is a screening test, meaning that it's not a diagnostic test. It's not a test that can tell you for sure or with certainty that a baby would have a genetic condition, but it's meant to tell you, is there a higher or lower chance for one of the conditions we can screen for?
Thank you for emphasizing that. I was about to ask you specifically about the screening nature of this testing, because I think it's really important that when the results come back abnormal in a screening test, patients understand that now we need to go to the next level, which is to actually diagnose the condition that we're worried about based on the screening test. So thank you for saying that. Can you explain how an amniocentesis and chorionic venous sampling, or CVS, are different from a prenatal screening test?
Sure. With prenatal screening, the pregnant person would have a blood draw, and then testing is done on the blood sample and is either looking at hormones or DNA that's circulating in the pregnant person's bloodstream. Prenatal screening is not 100% accurate, whereas amniocentesis and chorionic villus sampling, or CVS for short, those are procedures that are considered diagnostic. There are still always limitations to every test, but amniocentesis and chorionic villus sampling are able to determine if a pregnancy is affected with one of the chromosome conditions that we can screen for.
Speaking of screening tests, then, now let's just go back to where we started. Can you tell us about the different types of screening tests that are available?
The two most common types of screening tests that are offered early in pregnancy would be enhanced first trimester screening, or eFTS. This is a blood test paired with an ultrasound completed between 11 and a half and 13 and a half weeks of pregnancy. The other test that is offered commonly is called non-invasive prenatal testing. This is a blood test for the pregnant person, usually completed after 9 or 10 weeks of pregnancy. I would say most people are offered eFTS and NIPT, and most people will do one of those screen tests if they choose to have prenatal screening. There is another test that is available called second trimester screening. This is a blood test that someone could do in their second trimester of pregnancy after 14 weeks of pregnancy. And I feel like this is offered less commonly, but it is offered if people don't have the availability to do a nuchal translucency ultrasound, or perhaps they weren't offered testing or have learned about their pregnancy later on, this is an option that could be done in the second trimester.
So, you mentioned about the eFTS and the NIPT and second trimester screening, but does this vary across provinces across the country in terms of what testing people may be offered or what's available?
Enhanced first trimester screening and NIPT are offered routinely in pregnancy, but it will vary depending on your healthcare provider and perhaps where you're living within the country or in a different country. There are also different costs associated with the tests and what would be covered by a provincial healthcare provider.
Diane, is prenatal screening mandatory? Like everybody has to do it no matter what? Or is it an option that patients have? And why would somebody want to do prenatal screening? And why would somebody not want to do prenatal screening?
Great question. So, prenatal screening and any type of genetic testing is always optional. I think many people will choose to do prenatal screening because it allows them to have more information about their pregnancy. Many people do prenatal screening as they're hoping for reassurance. They're hoping to learn that there's a low chance for the conditions that we're able to screen for. When the testing indicates that there is an increased or higher chance for a specific condition, it allows people the opportunity to consider additional testing or to seek more information about that condition, to sometimes be prepared for the fact that their child may be born with that condition. Sometimes it means that their doctor will refer them to specialists to learn more about what that would mean for their child, or even have specialists on hand at the time of delivery if we know that there are certain health issues that could be expected for their baby. On the flip side, some people choose not to do prenatal screening. Some people maybe don't want to learn if there's a high chance for certain conditions in their pregnancy. Maybe they, in general, feel that there is a low chance and they feel comfortable not to have prenatal screening. I guess some people, if they learned that their pregnancy was affected with a genetic condition, maybe they would consider stopping a pregnancy. And there are certainly many people that know that they would never consider stopping their pregnancy. And so for that reason, they may feel that prenatal screening is not going to provide useful information for them.
I think that's a really solid and important point, that just because you do prenatal screening doesn't mean that you are somebody who would stop your pregnancy if there was an issue. And often patients, and speaking with patients, they'll say, well, I don't want to do prenatal screening because I would never stop a pregnancy. It's like, well, that's not the only reason. You're absolutely correct. I mean, I think Dr. Garcia and I, we've been in lots of deliveries. I can think of a few where somebody may not have done prenatal screening, babies delivered, and suddenly babies having health issues, whether it's heart issues or something is going on, and suddenly now they need emergency care. And sometimes having that knowledge prior to delivery can change where you're delivering your baby, what specialists are going to be on hand, what kind of medical care they might need, sort of even shortly after birth. And so it's not just about stopping a pregnancy or not stopping a pregnancy. It's also about being prepared and then having all that appropriate medical care as needed at delivery or after birth.
Yeah, absolutely. I think many patients do opt to have prenatal screening to have more information and also really to give them that opportunity to prepare emotionally if there is a chance that their child may have a genetic condition. Some people have told me that it even allows them to perhaps share information or expectations with their family members and to allow their family to prepare for perhaps the birth of a child with a genetic condition.
So before we get into the nitty-gritty of genetics, can you give us a 2-minute primer on what are genes, what are genetics, what are chromosomes, so that we can all be speaking the same language?
Our genes and chromosomes are made up of DNA. So DNA is that molecule that we probably all know about. And our DNA is packaged into genes, so smaller units of genetic information. And our genes then are packaged into chromosomes. A chromosome is made up of hundreds and thousands of genes, which is made up of our DNA. So we should have 46 chromosomes in our cells, and we have 23 pairs altogether, or 46. Our 23 pairs of chromosomes come from the egg and the sperm at the time that a pregnancy is created. 23 should be coming from the egg, 23 coming from the sperm. And so that's what really results in 2 copies of each chromosome, or 46 in total. And so prenatal screening is screening for chromosome differences. generally where there's an extra copy of a chromosome that's present in the cells of a developing pregnancy or baby. Prenatal screening is not screening for things like single gene genetic conditions, which could include conditions like cystic fibrosis or sickle cell disease or Fragile X syndrome. These are all genetic conditions that are caused by very specific changes within the genes. Prenatal screening can also not screen for more complex traits or things like autism or ADHD, some forms of intellectual disability. Certainly, prenatal screening is quite targeted to what we are able to screen for.
Diane, you mentioned there's two types of prenatal screening tests, but before we get into the details of those tests, can you tell us in general what kind of conditions prenatal screening tests for and tell us a little bit about those conditions? Because we know it doesn't test for everything.
For sure. I think, in fact, prenatal screening is testing for specific chromosomal conditions. Enhanced first trimester screening is able to screen for two chromosomal conditions, trisomy 21 or Down syndrome and trisomy 18. Non-invasive prenatal testing, NIPT, can also screen for Down syndrome or trisomy 21, trisomy 13, trisomy 18, as well as sex chromosome differences. These are all changes that involve the chromosomes. And our chromosomes are those structures that are found in our cells that are made up of our DNA. And we should have 46 chromosomes in our cells. And we know if there happens to be an extra or missing chromosome, then that's something that can affect the health and development of an individual. Down syndrome specifically is caused when there's an extra copy of chromosome 21. We know that this chromosomal difference will cause developmental and physical differences in people with Down syndrome. The condition itself can really vary in severity. However, it generally will involve lifelong intellectual and developmental delay. Down syndrome is the most common genetic chromosomal condition in children, and people with this condition may have other health issues, including heart problems and gastrointestinal issues. We know that as we've learned more about this condition, we can provide early intervention, and this has certainly led to an increased lifespan and increased quality of life. Trisomy 18 is another genetic condition that involves an extra copy of chromosome 18, and this is a condition that's quite severe. Having an extra copy of chromosome 18 will affect how a baby will grow and develop. We know that this condition is less common than Down syndrome. We know that many pregnancies that are infected with trisomy 18 can result in miscarriage or stillbirth. Some babies can be born with this condition, and we would see that babies might have low birth weight, multiple birth defects, perhaps poor muscle tone, as well as significant intellectual and developmental delays. Babies with trisomy 18 usually don't survive for very long after birth. Sometimes they pass away early in life. Trisomy 13 is quite similar to trisomy 18 in general and can result in a very severe developmental and intellectual disability. And again, babies with trisomy 13 might pass away very shortly after birth. And as well, there is that increased risk for miscarriage or stillbirth in a pregnancy.
Talked a little bit briefly about the prenatal test, but let's get into things in a little bit more depth here. So, what is eFTS? What are you testing for? How good is it? When's the screening done?
eFTS is a blood test paired with an ultrasound that's completed at around 11 and a half to 13 and a half weeks in pregnancy. And as well, the age of the person providing the egg is also included in the calculation of what is the risk for having a baby with Down syndrome or trisomy 18. So eFTS is screening for Down syndrome, trisomy 21, and trisomy 18. And essentially, the testing indicates, is there a higher or lower chance for having a baby with Down syndrome? A specific risk calculation will be provided. So it might say that there's a 1 in 3,000 chance that the baby would be born with Down syndrome. Or it may say that there's a 1 in 200 chance that a baby would be born with Down syndrome. So it actually provides a specific risk assessment for Down syndrome. The cutoff or the risk when there's a screen positive result is any risk that is higher than 1 in 350. So if someone has this test and their risk comes back as 1 in 100, for example, that would be a high risk result or a screen positive result. Now, again, that result doesn't mean that the baby would be born with Down syndrome, but it means that there is a higher chance for the baby to have Down syndrome.
That's a really important point that I think is good to emphasize is that even if you screen positive on eFTS, that screen positive still means that the risk could be less than 1%, right? It's definitely not a diagnostic test and it's probably not time to quite panic yet, right? But it's the way that the screening and the cutoffs are set. Because again, somebody made the choice, right, to set that screening at that point is really just hoping to try and capture anyone who may possibly have a pregnancy affected by Down syndrome. And I think that that's a really, really important thing to think about, especially for those patients who do end up screening positive.
Exactly. When we're doing eFTS, what's being measured in the bloodstream of the pregnant person are hormones and proteins that are being produced during the pregnancy. And if those hormones or proteins are a little bit higher or lower than what we expect, then that is part of the calculation that can tell us if there's a higher or lower chance for a baby to have Down syndrome. But sometimes those levels might be higher or lower, in a pregnancy, and it doesn't necessarily mean that the baby has Down syndrome. Another important consideration for eFTS is the age of the pregnant person or the person who's provided the egg for the pregnancy. This is important because we know that there's a higher chance for chromosomal conditions as the age of the egg or the person providing the egg is getting older. So there is that relationship with the age. And the nuchal translucency measurement is also important. So that's that measurement that's completed at the time of the 12-week ultrasound that's looking at fluid at the back of the baby's neck. And we know that if the amount of fluid behind the neck or under the skin is in the normal range, then there's a lower chance for a baby to have Down syndrome. But if that fluid amount is elevated, then that can be associated with a higher chance for Down syndrome or other chromosomal differences. So all of those things are important with eFTS. But again, it's still not a diagnostic test. And you're absolutely right. Sometimes we might have a higher risk result, but that does not mean for sure that the baby would have Down syndrome. The detection or I don't want to say accuracy, but with eFTS, we know that that test can detect about 89 to 90% of pregnancies with Down syndrome. So that means that the test will not detect all pregnancies with Down syndrome. And on the other hand, sometimes we do see false positive results, which means that there can be a high risk result, even though the baby does not have Down syndrome. So that's important to keep in mind. And the false positive rate for eFTS is about 5 to 6%. And that just means that most people who have a screen positive eFTS would consider additional testing to have a more diagnostic result or a more accurate result about the risk for Down syndrome.
Thank you for that explanation. Can we now talk about NIPT and how it is different from eFTS?
For sure. NIPT is similar in that it is a blood test. So again, it's a blood test for the person who's carrying the pregnancy. And with this blood sample, we're now looking at cell-free DNA circulating in the pregnant person's bloodstream rather than hormones that we're measuring when doing eFTS. So NIPT is a better screen because we are looking at the DNA. And we're analyzing the amount of the DNA in the bloodstream, and we're able to be measuring DNA from the pregnancy, which is truly from the cells of the placenta, and also looking at DNA from the pregnant person. With this screen test, we can screen for more chromosomal conditions. So we can screen for Down syndrome, which is trisomy 21, trisomy 18, trisomy 13, as well as those 6 chromosomes. And the accuracy for Down syndrome specifically is greater than 99%. So that means that the detection rate for Down syndrome is greater than 99%. And we see less high risk results with NIPT and lower false positive rates with NIPT as compared to eFTS. So there's a higher detection rate for Down syndrome and also lower chance of a falsely high risk result.
eFTS and NIPT, as you mentioned, are similar in that they're both screening blood tests, but they're different in that the eFTS is looking at hormones and the NIPT is looking at cell-free DNA. So they're also different in their ability to pick up the conditions, and the false positive rate is different as well. Also, NIPT can test for conditions that the eFTS cannot, such as trisomy 13 and sex chromosomes. Can you also tell us about the difference in costs for the eFTS versus the NIPT?
In Ontario, eFTS is covered by OHIP for all pregnant people, whereas NIPT is only covered in some situations. And so NIPT would be covered if the person providing the egg is over the age of 40 at the time of delivery. The NIPT is covered if there's a higher chance based on ultrasound for having a baby with Down syndrome or another chromosomal condition. If someone has had a previous pregnancy with Down syndrome, trisomy 18 or trisomy 13, then NIPT would also be covered by OHIP. And twin pregnancies are also covered by OHIP with NIPT. And in fact, NIPT is the test that would be recommended for someone who is in a twin pregnancy.
You mentioned cost as being one big differentiating factor between NIPT and eFTS, but it sounds like NIPT is a better test. Like it gives you more accurate information and it doesn't involve an ultrasound. But what are some of the other potential, let's say, pitfalls of NIPT?
One important point with NIPT is that there must be enough cell-free DNA circulating in the bloodstream in order to complete the test. And so there are some people, a small number of people that do NIPT that might have a no result or the NIPT test is not successful. And one of the reasons for that is that there may not be enough cell-free DNA available to complete the analysis. There are different reasons why we might see, we call it low fetal fraction, which means that there's a lower amount of DNA from the pregnancy in the bloodstream. And there are different reasons why this could occur. One reason is that the blood was drawn too early. So with NIPT, it's very important that blood is drawn either at 9 or 10 weeks and onwards in the pregnancy, depending on which test or which lab you're working with. Another reason we might see a lower fraction of DNA is that people with a higher BMI or body mass index, we might see a lower amount of DNA from the pregnancy in their bloodstream. We also do see that there's a higher chance for no result or a low fetal fraction in people who've had IVF to conceive. This could be attributed to perhaps medications that someone might be taking as part of their IVF cycle, or perhaps an underlying condition that is, part of their infertility. I think that, it's important to keep that in mind, although I would say that it's also important to note that most people who do NIPT actually have a successful result, but this is something to consider. And I think with that, when someone has NIPT and the lab tells us that they weren't able to analyze that sample, perhaps due to a lower amount of DNA, one option would be to provide a second sample. So usually the lab will request that a second sample is provided. And I would say that most often a second sample will result in a successful result. But that's something to keep in mind. And I think we don't see the same sort of chance of an unsuccessful test or an inconclusive result with eFTS.
Another question that I have for you, we know that for the NIPT, the patients have the option to test for the main conditions, which is trisomy 21 or Down syndrome 13 and trisomy 18 and the sex chromosome, but they also have the expanded conditions and the microdeletions, which it's a little bit more controversial. So can you talk about that? Let's say I'm a patient that is trying to make a decision about whether to do the extra testing or not. What should be considered?
That's a really great question. NIPT is known and best, I would say most accurate or has highest detection rates for Down syndrome, trisomy 18, trisomy 13. We actually see a little bit lower detection rates and maybe higher chances for an inconclusive or false positive result with the sex chromosome aneuploidy or chromosomal differences as well. And you're right, there is the option to test for microdeletion conditions. Microdeletion conditions result when there's a very small deletion on a particular chromosome, a very specific region of a chromosome. And the NIPT labs do offer the option to screen for one or more microdeletion conditions. In general, we know that the testing is probably not as good for the microdeletions and that there may be higher chance for false positive results for a microdeletion condition. And so I think that This is important to keep in mind. Certainly, some people, when considering NIPT testing, will tell us that they want to screen or test for as much as possible. They want as much information as possible and maybe are aware that these microdeletions can be screened for. I would think it's important to know that if you choose to screen for a microdeletion condition and your NIPT result comes back saying that there's a high risk or an increased risk for one of these conditions, that again, that does not mean that the pregnancy or baby will for sure have that genetic condition. In that case, there would be certainly a recommendation to consider diagnostic testing, such as amniocentesis, for a very conclusive result with regards to the microdeletion. Microdeletion conditions in and of themselves are quite, I don't want to say rare, but not as common as Down syndrome or chromosomal conditions. But collectively, we know that probably in pregnancy, maybe about 1% of pregnancies can have a microdeletion. But there are so many microdeletion conditions, and NIPT allows us to screen for a few of these microdeletion conditions. So it's important to keep that in mind, that with NIPT, we can screen for perhaps a few of them. This brings us back to, amniocentesis and CVS, and just keeping in mind that those are diagnostic tests. These are tests that are available to screen for all of the chromosomes in a developing pregnancy. And amniocentesis allows us to have a sample from the amniotic fluid and truly DNA from the developing fetus, and is going to give us the most information.
I have to say, I think another big distinguishing factor between eFTS and NIPT, and I think a lot of reasons why I hear patients do NIPT is that you can find out the sex of baby a lot earlier. And a lot of patients just don't want to wait until their, 20-week anatomy scan. But certainly with the NIPT reporting system, you can find out the sex of your baby even in the first trimester. And I think that motivates a lot of people to do it.
I would agree. I mean, I think certainly in the fertility clinic, I certainly hear that people want that information. You're right. It allows them, one, to have the information and earlier in pregnancy as well. So I think some people do feel that that's either, the reason that they're doing the testing for some people, or perhaps a bonus. I guess as a genetic counselor, I feel that people should be considering the possibility of all of the possible results and know that they could have results that indicate an increased risk, that the test is not only to learn about the sex of the baby, but I think it can be an added bonus.
Let's talk about a specific scenario here. So let's say a patient did IVF with PGT and transferred a chromosomally normal or euploid embryo. Should that patient still have prenatal screening, and what type of prenatal screening would be ideal for that patient?
Yeah, that's a great question. So everyone in pregnancy can consider prenatal screening, and everyone's situation is unique. So that's important to keep in mind. There's important considerations when thinking about what prenatal screening test to do. We think about whether someone has conceived with IVF, and if so, have they had PGT-A for their embryos? If they have transferred a euploid embryo, then that means that they have already had a good screen of the chromosomes in the cells of their embryo. We know that PGT-A testing is also a screening test, and so not 100% accurate. And I think that's why some people may consider doing prenatal screening once they're in a pregnancy. It offers them the opportunity to do another test that can give them reassurance, because PGT-A is a good screen already of all of the chromosomes. So all 23 pairs of chromosomes are screened with PGT-A. People who've done that test on their embryos have had a good screen. It's for them. It's not recommended that they do eFTS, because eFTS is actually less accurate at screening for Down syndrome or chromosome conditions than PGT-A, and also screens for fewer genetic conditions. So I think eFTS is not recommended, although we would still always recommend that someone consider their 12-week ultrasound with the nuchal translucency component as part of that ultrasound, even if they don't do eFTS. On the other hand, people can consider NIPT as a screening test if they've done PGT-A. And I think we would always want people to understand what PGT-A screens for, what the limitations are, how does it compare to NIPT. NIPT is generally more limited in screening for only some of the chromosomes that PGT-A has screened for. And so it's important to just have a really good understanding of what each test screens for and what it doesn't screen for.
Yeah, I think it's important to understand that one test doesn't exclude the other. So just because you did PGT and transfer a euploid embryo, it doesn't mean you don't have to do an IPT. You could still do an IPT. You might choose not to for a lot of reasons, but you certainly are still a candidate and should have the discussion with your physician about the options for prenatal testing, in particular, like you mentioned, the NIPT.
I can add one more thing. I would say that when doing PGT-A, it does not screen for microdeletions, which are those really small deletions along the chromosomes that we were speaking about. And so I certainly do have people that ask me about doing NIPT, and if they've done PGT-A testing for their embryo, they may want more information about the microdeletions that we can screen for with NIPT. And ultimately, some people do choose to screen for microdeletions. Screening for microdeletions with NIPT is generally not recommended by our governing bodies, by, their professional organizations because of the limitations. But I think some people do opt in for the microdeletion screening. I think as long as they're well informed about the limitations of that testing, it is something that they might consider.
So let me ask you, Diane, pregnancies that are conceived with donor eggs or donor sperm, or pregnancies that are conceived using a gestational carrier, do those pregnancies have specific situations that we need to be aware of in terms of the types of genetic screening that are offered for those pregnancies?
Yeah, I think it's always important that your physician knows that you've used a donor sperm or donor egg to conceive or a gestational carrier. I think we can still consider prenatal screening in any of these situations. I think when doing prenatal screening, we always want to ensure that we think about the age of the person providing the egg. So that's very important to share with your ordering physician. And there are some differences in what can be tested for, depending on whether you've used a donor egg and or a gestational carrier or surrogate. So this is certainly information to make sure is considered at the time that the test is being ordered.
How about for donor sperm? Is there specific differences for donor sperm?
There's really not any difference for a situation where a donor sperm has been used. So eFTS or NIPT can both be offered.
Another common scenario, or I guess not so common scenario that comes up that can sort of has some nuances to it with genetic screening is in the case of people who are pregnant with twins. When somebody is pregnant with twins, whether it's via embryo transfer of a euploid or whether they've conceived via IUI or naturally, what is genetic testing? What does prenatal screening look like for them?
That's a great question. So, non-invasive prenatal testing, or NIPT, is a screen that's recommended when someone is carrying twins. In Ontario, that testing would be covered. And again, there are different labs that offer NIPT. So, it's important to make sure that you have a good discussion, perhaps with your doctor or a genetic counselor, if you're able to know what information can be reported when it's a twin pregnancy.
Along those lines, we talked about twins. What about higher order multiples? What about if someone's pregnant with triplets? Or what about a situation with a vanishing twin?
Great question. So, when there are triplets, for example, the only option available for prenatal screening would be the nuchal translucency ultrasound only. So, that's that ultrasound at 12 weeks. That's looking at the fluid that's present under the skin at the back of the baby's necks. Unfortunately, enhanced first trimester screening and NIPT are not available with triplet or higher order multiple pregnancy. So vanishing twin, just to clarify, this is a pregnancy that started out as a twin pregnancy or more than one pregnancy where one embryo or twin has stopped developing early on. In this situation, eFTS or NIPT is not generally recommended because the hormones or DNA from the twin that has stopped developing can still be present in the bloodstream of the pregnant person, and it can interfere with the screening results and the accuracy of the screening results. In this case, what would be recommended is the NT ultrasound, that ultrasound again at 12 weeks of pregnancy with NT measurement, and then blood work in the second trimester. So second trimester screening, which is looking at hormones produced by the pregnancy in the pregnant person's bloodstream and can indicate if there is an increased risk for Down syndrome or trisomy 18. And it is recommended that there's sort of a gap of about 8 weeks before doing that second trimester bloodstream from the time that the twin stopped developing.
I have to say, there are so many nuances to the world of prenatal screening. And there are so many particular scenarios or situations that can come up that can kind of throw a wrench into what our ideal prenatal screening route may be. And so I'm just so grateful that we have an expert literally just down the hall from me that I can call on or knock on your door if I ever have any questions, because there are so many subtleties and things that can affect prenatal screening results. And this is really important because there are patients who these results are so crucial and so important. We want to be as accurate as possible and to give people the best information that we can.
You're right. There are so many nuances, and everyone's situation is unique. And I would say if you're doing prenatal screening, if you do have an increased or a high risk result, then please ask for a referral to a genetic counselor or to a genetics clinic for a good discussion of your results and an opportunity to learn about all of the testing options that would be available to you.
Thank you so much, Diane, for coming again on My Fertility Podcast. We love you here at Markham Fertility Centre. You're a big part of the secret sauce to our success and a big part of the team. So thank you for sharing your knowledge of prenatal testing options with our patients and the fertility community at large today.
I love being here. Thank you for having me.
And for listeners who are interested in other topics related to prenatal screening or other aspects of genetic screening or genetic testing, you may want to check out the following episodes. So, episode 29, we had Diane where we were speaking about expanded carrier screening. Episode 30, we spoke about pre-implantation genetic testing, specifically for aneuploidy or PGT-A. And episode 36, where we did another episode on pre-implantation genetic testing, we were specifically talking about monogenic disorders. So, if you love Diane like we do, check out episode 29, episode 30, and episode 36. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markhamfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.